There's no question that it's very important that you know how a machine works and what the technical principles are, but I still believe that it's even more important that you know how to image patients and get good image quality, because after all, it's those images that you're going to interpret. So the learning objectives of this chapter are how to find the windows, how to image the heart and especially focus on practical issues, what the standard views are, and also that there are atypical views that are very helpful in many clinical situations, what the individual views are good for, how and when to use M-mode and Doppler, and what is part of a routine exam. So first I'll talk about the transducer itself, and then how to hold the transducer, how to move the transducer. I'll talk about the problems that we have with lung and ribs, and then finally I'll talk about the different echo windows that we have. So first of all, let's take a look at the transducer itself. A few things are important to know about the transducer. The first thing is that there's a marker which shows you where the orientation on the screen is. You can also feel the marker here. The second thing is that the crystals and the ultrasound beam is emitted from a rectangular area. So it is not the same if the transducer is oriented in this direction with respect to the intercostal space or this direction, because here you will obscure your view. The other thing that is important is that if you need to tilt the transducer, you will have the problem that you will obscure your view if you tilt it this way. So in this case, you'll have to move down a bit, move away from the ribs, and then you will get a good view within or in between the intercostal space. So how do you hold the transducer? Well, I guess everybody does it a bit differently, and I will just show you how I would hold the transducer. The first thing which is of importance is that you hold the transducer low and not high. Thereby you have more stability and more control over your motion. The second thing is remember where the marker is. You have a little marker here, and with my finger I can feel the marker. This does not necessarily have to be the same finger all the time. For example, if I rotate the transducer, I would then feel it on the thumb, but thereby you always know in which rotational state you are. The next thing which is very important is to try to have body contact. So I try to leave my whole entire hand on the body, and thereby I have much more stability versus holding the transducer like this. And the other thing which is very important is that when you rotate, at least that's what I would do, is I have my little finger, and my little finger kind of gives me an anchor here. You see, this is the anchor, and when I rotate the transducer, I always know where I am, and I don't lose the position while rotation. So in summary, you have several ways of manipulating the transducer. You can displace it, you can angulate it, or you can rotate it. By looking at the screen, you see what happens when you do these manipulations, and thereby you can correct your image. Very important, the transducer has a marker. The marker shows you where the position on the screen is. And each sector obviously also has a center line, and this is the rotation axis. So when you rotate the transducer, you'll always rotate around this axis. If you lose your axis, if you tilt the transducer, for example, during rotation, you'll always lose the structure that you want to visualize because it will get out of your view. So the problem with imaging the heart is that we have the ribs, the sternum, and the lungs, which can obscure your view to the heart. It's also very important to get good skin contact. Let's see how we can achieve good skin contact. I think image quality is probably the most important, or one of the most important things in echocardiography. And to really get a good image quality, you need good contact with the transducer to the body. And I will show you a few things which you should keep in mind when you image. We have a patient here who is certainly not obese. He does not have very much subcutaneous tissue. And if we perform echocardiography on him, we will have fairly good contact if we image the patient perpendicular, transducer to the body. However, as soon as we tilt the transducer, I will just show you from here, you will see that we lose contact. And since we cannot get images ultrasound images through air, we have to apply ultrasound gel. And I will do that right now here. You see, I will put some ultrasound gel here, and all of a sudden we have contact again. Now, I will get good image quality, but if I perform echocardiography and I move the transducer around, all of a sudden I will lose the contact again simply because I'm smearing the ultrasound gel throughout his body. So we have to repeatedly use ultrasound gel to optimize the image quality. The other thing which is important is you have to apply some sort of pressure. It's always a question of how much pressure should you apply. I believe that you certainly should not harm the patient, but you should use the subcutaneous tissue to embed the transducer. I will do that here from a subcostal view. Okay, you see, we do not get a very good image quality. However, as soon as I kind of move the transducer into the body, the image quality improves. So I'm embedding the transducer in the subcutaneous tissue and thereby improving the image quality. So this schematic shows you what the problems are if we want to image a structure which is behind the ribs. We obviously can't image right through the ribs, so we have to use intercostal spaces. But if these spaces are very narrow, you will have artifacts here at the side of the ultrasound beam which do not give you a view to the image. There's a little workaround. If you move the transducer up a bit and you're on a rib which is more cranial and you angulate the transducer more and you use a lot of gel, you can actually image right behind the rib. So this is a little trick that you can use, especially in situations where patients have very narrow intercostal spaces. We've already talked about the impact of air on image quality. So it's obviously a difference if the patient inhales or exhales. Let's take a look at what happens if the patient breathes. The lung has a very big impact on the quality of the images, simply because we cannot image through air, and if the patient inhales or exhales, we will change the windows and thereby change the quality of the echocardiogram. So I will show you what happens when a patient inhales. We have a normal 4-chamber view here, which has a very good quality, but can you please inhale? As soon as the patient inhales, the window vanishes and we will not get an image. Exhale. As soon as the patient exhales, the image is back. So remember this and use maneuvers such as inhaling and exhaling to optimize your image. This is just an example to show you that the image disappears when you inhale, but there are situations where it is better if the patient actually inhales. Sometimes the patient have better image quality if they inhale. This is especially true for the 2-chamber view, and I'll try to demonstrate that here. This is a patient who has moderate quality of the 2-chamber view, and I will now ask the patient to inhale. Können Sie mal einatmen? See, and immediately we get, das ist zu viel, ein bisschen ausatmen. We get better image quality. Sometimes he should not excessively inhale, as in this case, but if he inhales moderately, you can see the anterior and the posterior wall much, much better. Despite the fact that we have the ribs and the lungs and the sternum, which obscure your view to the heart, there are still several windows from which we can get a view. There are 3 standard views, or standard windows: the parasternal window, the apical, and the subcostal view. And then there are 2 additional windows which we use under certain circumstances. The parasternal window is located left of the sternum, the apical window at the apex, and the subcostal view right below the xiphoid. Finally, I just want to mention that it makes a difference if you image a patient who has a normal habitus or athletic habitus, or if he is more picnic, asthenic, or obese. These types obviously influence the position of the heart and thereby your transducer position and also the window. But I'm certain that if you image a lot of patients, you will intuitively know which patient type will have to be imaged from which position or where the window is in these patients. So let's start with the first window that we use in every patient, the parasternal window.